What I'm going to talk about today is looking through this a little bit differently. Instead of thinking about symptoms, what I want to focus on is the gap in life expectancy between people living with a mental illness and people without. So for those that don't know, that gap is up to around 15 years. Some estimates are as high as 25 years. Overwhelmingly, that gap is not due to suicide. It is due to preventable premature cardiovascular disease. And of course, we're here talking about exercise. One of the cornerstones of treating cardiovascular disease is physical activity. So I'm going to come at this from a slightly different lens, thinking about the physical health consequences, and present some work on behalf of our team, particularly Dr. Scott Teasdale, and I'll talk about that. I'm going to structure this around two key reports that I'm hoping people here that are working in community programs, are running initiatives, trying to get resources, two international reports that might be able to help provide a little bit of justification, policy work that can help justify the fantastic work everyone is doing. So the first one, and this was a report released from the World Health Organization earlier this year, and this is their guidance on mental health policy and strategic action plan. And for those that haven't seen this, I'd highly encourage everyone to have a look through this document. Now, together with some colleagues, Joe Firth, Kathleen Latimer from the Olympic Refuge Foundation, Brendan Stubbs, Grace McEwen, Davey Van Kampfort, we've looked at this document through the lens of physical activity, exercise, and lifestyle interventions. And I'm going to give you 5 sentences here. On the left, you can see the module. So that's the specific WHO document. You'll see the key message from that document, and then what are the implications for exercise? And what are the questions? So the first one, module 2, and I'll just go to the reflective question. Are we treating exercise as an essential right or an optional extra? Yeah. The other thing to mention is that all the way through this document, exercise, sports coaches, physical therapists are written all the way through. Module 2, Directive 5.1, thinking about evaluations and thinking about the outcome measures. What are we measuring? And are we measuring what's important to people? Yep. Again, Module 2, 2.1, services shouldn't only be embedded in communities, but need to be placed where people are. So a lot of the work that we're doing in Australia is trying to think, how do we reorient these interventions? How do we take them out of the clinic and put them inside community services where people are accessing? So, for example, we're working with refugee health services, we're working with homeless shelters, we're working with food pantries to put exercise and nutrition interventions into those services upstream where they're needed, where they can help with prevention. Thinking about the workforce and thinking about task sharing in low resource contexts, and I'll talk a bit about that, but who counts as a mental health provider? And I think this is a conversation that increasingly we need to be talking about. Again, we're not saying that we don't need mental health professionals. That's absolutely critical. But these interventions, given the weight of the evidence we have, should be implemented alongside. People should have equal access. Thinking about providing a flexible, culturally responsive menu of interventions, and Rebecca's talk yesterday, thinking about that smorgasbord and how do we ensure that we're providing a range of options, and what Francine talked about as well. So offering meaningful choice to participants. And finally, this idea that we can reduce burden on the mental health system and the health system in general by actually investing in these interventions. And that's not a surprise to anyone here. The last one, which I really like, the language in this report around rights-based language, dignity, autonomy, how these interventions fit into that framework, shifting from treatment to agency and participation, and ensuring that our services can support self-determination. Okay, so that's that document. Again, it's all online, it's freely available, and hopefully we'll have this editorial published soon. I'm going to shift now to talk about the Lancet Commission on Protecting Physical Health. So for those that aren't familiar with what this means, the Lancet is a medical journal. It's a very influential, important medical journal. Every year they have commissions on topics they deem of being globally important. So I'll give you some ideas about some of the other commissions that we've had: back pain, opioid addiction, climate change, gender equity in medical research. So really big topics. The fact that in 2019 we had a commission on the physical health of people living with mental illness speaks to how important this issue is. But things have changed a lot since 2019. So 2019, led by our colleague Joe Firth, this was the first commission. It was a blueprint. It was called a blueprint to protecting physical health in mental illness. And that infographic you can see on the left were the issues, and on the right were the actions and suggestions about what mental health services can do. Fast forward 6 years, and led by our colleague, Dr. Scott Teasdale, who is a dietitian, a mental health dietitian, and he co-leads, together we co-lead our research group in Sydney. And Scott led this update of the commission. It was a whole paper on implementing lifestyle interventions in mental health care. And really, I have to credit Scott. This was an incredible amount of work over the past 2 years. So all credit to Scott and Joe Firth for doing the bulk of the work. So the shift here was about how, and this whole report talks about what are the practical steps we need to take in order to implement these interventions as part of routine care. So there's 5 parts to the commission. I'm not going to go through it in great detail, but essentially the first one was looking at what's the impact of the 2019 commission. So we did some analysis looking at the citations and looking at looking at the evidence since. We did a lot of evidence reviews looking at what have been the interventions and the trials published since 2019, trying to pull out the effective components and what are the bits that are actually replicable across different services, different countries, different contexts. We then did some qualitative reviews looking at the barriers to implementation and also facilitators, again, at different levels of the system, at the organizational level, at the micro level. And finally, what are the recommendations going forward? Now, really importantly, there were 3 parts to this. One part was reviewing the scientific evidence. Another part was we formed a lived experience advisory group made up of service users across 2 countries. They reviewed all the recommendations and all the evidence alongside and provided their input to make sure that what we ended up with in the final report was actually useful and reflected that rights-based language from the World Health Organization. The final group we had was what we called a Global South Advisory Group. Now, I know that word is not ideal depending on context, but essentially it was made up of authors, colleagues, and researchers from countries outside of America, Europe, and Australia, essentially. So the global majority. That name, Global South, is not ideal. We asked the group of colleagues how they wanted to refer to that group, and that's where we landed. So we could get into an academic debate about that, but we landed on Global South Advisory Group. So again, it was just to show that we've got those 3 pathways here, that all the evidence was synthesized through into the final report. So the impact of the 2019 commission, I'm not going to talk about where it was cited and all that stuff. There's 2 things I want to point out. And one is the affiliation of the primary author. So this was 88% came from a high income country. Essentially, you can see the map here, Australia, the US, and Europe. There's a big gap here. The global majority is just not being represented in the literature. If we look at the intervention studies, it's even worse. 92% came from essentially Australia, the UK, and the US. So this was part of the justification of needing that Global South Advisory Group and ensuring that we've got diverse voices at the table, informing this evidence and what we're doing going forward. What do lifestyle interventions currently look like? So in this section of the report, we summarized 99 reports, including about 89 unique interventions. We had 6 case studies, and I'll give you just 2 examples now. One was Live More Gyms, which is Matt Waugh, who's a psychiatric nurse in the UK. He's done an incredible amount of work setting up gyms within the NHS, inside inpatient mental health units. He's got some fantastic resources online. That was one of the case studies. Another one of the case studies was work I've been involved with the Olympic Refuge Foundation, developing training for sports coaches working in conflict-affected regions, particularly this in response to the Ukraine crisis. So how can we think about sports coaches as being another avenue, another potential member of the mental health team who can provide these interventions? We looked at, so those case studies were again, Global North and Global South, inpatient and community settings. And we looked across the spectrum of lifestyle interventions, so physical activity, nutrition, smoking, and sleep as well. This is an example about what those case studies look like. So there's 6 of these. This is the Sport Coach Plus training. It has the inputs, the funding. It talks a little bit about how these can be replicated. And this is for all 6 of those case studies. I'm sorry, it's a bit small there. The report's available online, and I can share it as well. Something I didn't talk about was this QR code. So again, thanks to Scott, this was an enormous amount of work that went into that QR code. What it is an Airtable. And for those that aren't familiar with Airtables, it's essentially a searchable Microsoft Excel, a searchable spreadsheet. But what you can search on this QR code is all the lifestyle interventions published since 2018, all the big trials, and you can search by inpatient status, outpatient status, whether it was smoking, whether it was multimodal intervention. So it's an incredibly useful resource for people looking at implementing lifestyle-based interventions. And just an example, I mean, that QR code was just an idea we had. Scott then had to go and execute, and he did an incredible job. It took, months and months of work. So it's a really useful resource I'd encourage people to use. You may need to sign up for an account. It's free, but you just might need to put your email address in. Okay, so part 3, what are the effective components of lifestyle interventions in mental health care? Again, this is very high level summary. So firstly, grounding interventions in one motivational theory, offering both individual and group-based sessions. This is what the evidence tells us, which makes sense if we think about it. Some people aren't ready to come to a group-based session. They need support through one-on-one training, then they'll engage, and then they're going to disengage. So we need to offer both. Offering a range of intervention approaches. Again, this has been covered so far. Integrating health coaching, behavior change techniques, and motivational interviewing. Integrating exercise and nutrition specialists. And the evidence is very clear on this. When we have dedicated trained practitioners, we have lower dropout and more effective interventions across diet and exercise as well. So the quality of that intervention, the quality of the supervision is absolutely key. Interventions should be at a manageable level to start with. That's not news here. These need to be prevention focused. So taking an example, early psychosis, young people commencing antipsychotic medication, the metabolic damage of that medication is rapid and immediate. It's in the first 12 weeks. We've got good evidence now that came from Australia. We can prevent antipsychotic-induced weight gain if we intervene at day 1. So it's really important that these interventions are prevention-focused and used immediately, not once the damage has already been done. And inpatient, outpatient, and community settings we should be prioritizing. This was the qualitative review looking at the barriers and enablers to implementation. So this is looking at a system level. We then looked at the macro, the meso, and the micro level, and what practical steps can be taken. And this ranged from engaging different stakeholders. These are going to be some broad statements, but the evidence is all in the report. Collaborative governance is absolutely critical in ensuring representation at all levels of the services, and that includes funding, reimbursement, and payment methods, which I think here in the US is even more complicated. In Australia, it's a bit more simple. We're still not perfect, but it's a bit stronger. Some of the meso levels, so organizational factors, thinking about strategic alignment between policies and then action, and the resourcing for that is appropriate. Capacity building is absolutely critical. We need to think about how do we build exercise and lifestyle capacity in our mental health workforce, but likewise, how do we do the same in the exercise, nutrition, diet workforce? They need training in mental health. They need training in trauma-informed practices. Culture change, and I spoke a little bit about that at the panel yesterday, but we've got good evidence around the importance of culture change, working with mental health providers, with mental health services to ensure that these are integrated as part of core business. It's not an optional extra. I'm not going to go through all of these, but again, data systems, ensuring that we're measuring things like exercise and physical activity, and also ensuring that we've got those clear referral pathways is absolutely critical. Task shifting was something that came up particularly in the Global South Advisory Group. And for those not familiar with this term, it's thinking about how can we use existing members of a health team, and they could be lay health workers, it could be sports coaches. How can we upskill them to be able to provide a more evidence-based intervention and task shift what they're actually doing? And then at the micro level, collaborative learning, management support keeps emerging as a critical factor. When we have champions and management within the mental health service who are engaged, there seems to be much better outcomes, which again, not a surprise. This should all make intuitive sense. So thinking about how the next steps and just some of the summary points from both our lived experience group and the Global South group, the lived experience group had concerns that the word lifestyle is narrow, and we totally agree. And in different cultures, in different contexts, it means different things. What they spoke about were things like social determinants of health, intergenerational trauma, systematic exclusion from programs that they wanted to access. So they agreed in general that these interventions were important, but they had other factors that they felt were critical that were preventing them from engaging. And so that framing of lifestyle and exercise, I think that's really important advice that we take on board. Thinking about autonomy and obviously co-production as being the essential first step. So needing to ensure that people with lived experience, that's saying nothing about us without us, that we don't do anything without, having meaningful engagement with people with lived experience. This was our Global South advisory group. And, I want to acknowledge colleagues from Brazil, Colombia, Nigeria, Rwanda, Egypt, India, Bangladesh, Myanmar, Indonesia as well. So the fantastic group of psychiatrists, mental health nurses, physiotherapists, people working at the intersection of mental and physical health in context with far less resources than what in the US and in places like Australia we're very fortunate to have. Just two people I want to mention here is Natalia Gringo from Ukraine, who was co-chairing that group, and also Dr. Indu, a psychiatrist from Kerala in India, and they chaired that group. Particularly Natalia and the work that she's doing in Ukraine, given the current situation and ongoing war that's happening there. For me, it was really interesting reflecting on, her engagement in this process, because a lot of people would say, well, this isn't a priority in some way like that, but actually a mental health professional in that region saying otherwise and talking about the importance of these sorts of interventions. Again, just want to acknowledge Scott. That's Dr. Scott Teasdale on the left. We did get some national news coverage around this, which was fantastic. Also with consumers that were able to come and share their story as well. Finally, for those interested in this, there is a broader movement here, and the LifePsych group led by Joe Firth and Phil Ward is increasingly looking at how we can host training and share resources around these sorts of interventions. I'm going to shift focus now to talk about some programs. We do have a YouTube video that hopefully will magically appear. Yep. Thank you, Nick.
تنفسي، استمري، ركزي. اسمي آهين، رشا، تغريد. أنا اسمي وفاء. أنا اسمي نور. وأنا اسمي هلا. أنا من سنجار. من الموصل. من سوريا. من سوريا. سوريا. من الموصل. داعش أجي كان عمري 7 سنوات. كنت أشعر بالخوف. بعدين على مود نزحنا وجام يعني ما عندنا أي شيء. أنا صار لي تقريبا حطب 10 سنوات أنا بالكامب. هيا مو كلش سهلة خصوصا بالكامب. بالنسبة للبنية كلش ظلم عليها إنه ما تاخذ حريتها. أهلها إنه ما يخلوها تشارك بهذا الفريق على مود العالم كلها تحكي، فيقصون عليها بهالظروف، إنه ما يخلوها تطلع وتشوف حريتها، إنه من ناحية العالم تحكي والعادات والتقاليد. فمن الصادف طلعت، فقررت إنه أشارك بفريق بريتوران، أتعرف على بيئات مختلفة، أتعرف على صديقات، أغامر، نروح نركض، نشوف الأماكن. إحنا فريقنا نسميها عائلة بريتوران. إي حلو إنه البنية تفرض حريتها وإنه تطلع تروح تجي ويا صديقاتها. أكون وياهم، أشجع كان شغلة. أنا من أروح وياهم هيج أحس يعني إنه نفسيتي تغيرت و... يظل عندي حماس وقتها. أنا يعني الجروب بالنسبة إلي كل شي بحياتي. تأمل أبطئ كوني قوية.
Thanks, Nick, for making that work. So that's Free to Run. They're an absolutely incredible organization. I've been very fortunate to just recently join the board. They're doing some fantastic work in places around the world affected by conflict, focusing on gender empowerment, focusing on women through running. There's really some fantastic stories on the website as well. There's opportunities to sign up as an ambassador. If you're running in a race or participating in something, then please get in touch with their team. A little bit about the strategy and the work that they're doing. So there's 3 parts to their strategy at the moment. One is empower, one is equip, and one is move. There's some fantastic stories about where the founder of Free to Run, Stephanie Case, was a UN human rights lawyer. So there's some incredible stuff online. I'd really encourage people, if you get the chance, to have a look, and there's a QR code there to learn a bit more about Free to Run. All right, this is my last slide. So in the last 3 minutes, I'm just going to talk very briefly about 4 projects that we're running that sort of ties all this together, hopefully. So the first one, this was a project in Lebanon led by a colleague named Biat. And Biat is from Switzerland. He was a rock climber, and he also is very socially justice-minded. With the wars happening in the Middle East and the displacement into Lebanon, he became interested in seeing what he could contribute as a rock climber. So next thing, he built a mobile rock climbing wall that you can see there on the back of a truck. He drove it into the Bekaa Valley in Lebanon, a very high density of refugees, a lot of Syrians, a lot of Palestinians, and started running climbing sessions for young people living in the camp. Together with a colleague named Katharina Luttenberger from Germany, we were able to conduct a waitlist controlled trial looking at the impact of that intervention. You can see the results there. We published it last year in the Journal of Conflict and Health. That is the well-being outcome for young people. Importantly, this was not just refugees. This was also the host community. We've done a lot of qualitative work looking at the role of these interventions for social cohesion and bringing these communities together. One of the interviews I'll never forget was also gender issues. And one of the interviews we did that I'll never forget was a young man. And obviously climbing, for those that are familiar with climbing, it's not particularly gendered sport. Women can be, with flexibility and body to weight ratio, just as good, if not better than men. But this was a big learning for some of the participants, some of the men. And we got some great quotes where they said, I didn't know women could be this strong. I didn't know they could do that. So a big opportunity around that gender side of things. Biat is currently, I believe, in Syria, looking at bolting new climbing routes. And so for those interested to follow ClimeAid to see what he does next. In Uganda, another great program. This was another randomized control trial that we did together, led by Davy Van Camfort and Kathleen Latimer from the Olympic Refuge Foundation. Uganda, again, a big refugee hosting country. This study we did was with over 800 participants, both refugees, people from the host community, women, boys, and also people living with disability were included. We found significant impacts on suicidal ideation and also on mental health outcomes. Really importantly, between these two projects was we didn't just have sport coaches or just have physical therapists providing these interventions. It was very, very targeted that we had both mental health professionals and physical health or sports coaches working together. They participated in joint training, they worked together, they built those pathways. And I think that's a really important message for all of our programs going forward. How do we integrate these professionals, mental health and physical health professionals together? Sport Coach Plus, I mentioned this is work, again, funded by the Olympic Refuge Foundation, started in response to the Ukraine crisis with the aim of reaching 100,000 young people affected by displacement. Sport Coach Plus, it's freely available online, all the materials, they're open sourced. This is currently a partnership between what used to be the Red Cross Psychosocial Centre, it's now called the MHPSS Hub, and the Olympic Refuge Foundation. That's hopefully will keep expanding across 12 countries associated with the Ukraine response. And in Bangladesh, so that's Sport Coach Plus, training sports coaches. Work we've done in Bangladesh and that we're continuing to do is how do we support our mental health professional colleagues? How do we ensure that mental health professionals working in humanitarian contexts, but also in high-income countries have the resources, have the confidence, have the positive attitudes they need in order to integrate these interventions? And finally, I was very fortunate to be here last year and I spoke a lot about Addi Moves, but just to recognize the project that we're running back in Sydney. This is a free community gym, partly inspired by a lot of the work that Francine's doing, looking at how do we provide free services to disadvantaged communities. A key part of that is that it is a training facility. So we have our university students, our physiotherapists, exercise physiologists, about to have dietitians completing placement, their practicum in that facility. They're getting exposed to people that otherwise they would never have the opportunity to. So that idea about how do we take these interventions out of the clinic, put them into the community. I just want to acknowledge our entire team. So Scott Teasdale, Dr. Grace McEwen, who did some fantastic work leading the co-design process of that Addi Moves facility. So a big thanks to Grace. Dr. Oscar Lederman, he did an enormous amount of work on the culture change aspect of Addi Moves, providing staff interventions, getting all the staff on board, trained, aware of what we were doing. Uzma Chowdhury, a master's student looking at exercise for adult survivors of childhood sexual abuse. Dr. Kul Shakurt is a psychologist, a clinical psychologist working with us on how do we integrate these interventions. Carla Miranda, who is our admin manager, and nothing would happen without Carla. Dr. Shabuj Mistry, public health expert. Kemi Wright, exercise physiologist. Afsana Anwar, a food security expert from Bangladesh, currently working with us, doing her PhD in Sydney. Oliver Young, our research assistant, and Dina Bakhtiar, who is championing mental health physiotherapy in Indonesia for her PhD. Thanks a lot. Thanks again, Adel, and thanks everyone.
Yeah.